Hi, and thanks for joining the video. So I've got quite a bit I want to talk about with you, just to get across my perspective on things. So I recently have become a lot more interested in critical psychiatry, and that has come from my own personal experience of antidepressant withdrawal, which happened to me earlier this year, and it's really changed how I see certain aspects of how we practice in psychiatry, and I think challenging that is a good thing. What I do want to say, and I've got quite a lot I want to sort of get out on this video, and I want to be as quick as I can with it, so not to take people's time, but I'll have to occasionally just look at my notes just to remind myself what I want to say. But basically, I think challenging medicine or science, for example psychiatry, is actually a good thing. And what I've noticed, and I really disagree with it, is it's very easy to put anybody who puts a forward challenge into a kind of box of their conspiracy theory or their for example, anti-medication. And I fundamentally disagree with that. I think good healthcare, good practice should be challenged, because that's how we evolve, that's how things develop, that's how, even like with history, that's how we move forward. So that's a point I wanted to make. Absolutely will not be put in that bracket, and I think it's really easy to do that when anybody sort of challenges things, and I'm not sure why it happens. Maybe it's a level of defensiveness, I don't know, but I think it's a good thing to challenge. And I've certainly changed my perspective. And as I say, I'm absolutely not anti-psychiatry. I work as a psychiatric clinician. I've done so for nearly 20 years. And I am completely the opposite. I'm actually pro-psychiatry. And I think a lot of that is about how we think about it. I think there's a move towards perhaps reforming elements of psychiatry, which is a really good thing. So I've always practiced in a very holistic way, and I do think, you know, we need to move away from and I think we are doing, as other people well more qualified than me have said and wrote brilliant papers on, you know, that we are moving away from the biological model now. We need to think of other ways, because to me, clearly something isn't working, and I'll give you my thoughts on that. So in a previous blog I wrote recently on one of the online websites, I wrote about my own antidepressant withdrawal experience, which was really hard. I won't go into the symptoms, but it was really, really challenging. I got through it, but it really opened my eyes up to antidepressant withdrawal, or whatever it's called. There is absolutely some, I don't think we know all of it yet. And I am just a nurse, so I am not a doctor. This is not medical advice, but I have read around a lot about it. I've been through it, and I do feel there's definitely some kind of I believe, because I was exposed to these medications for so long, I agree with many other people. I strongly disagree with the chemical imbalance theory of depression, and I think that, I believe, it is near to being confirmed, or it's certainly well on its way to being challenged. I completely disagree with that chemical imbalance, but what I do believe, and what I think in my case, and I can only speak from my experience, is from long-term exposure to the SSRI. Every time I tried to get off the drug, I went into a extremely depressive state, catatonic, I would say. I became non-functional for a few months. I'm functioning now, but that's what happened. I never had that before. I want to put out that I'm not questioning mental illness. I know that's very, very real, and I think treatments need to be very individualised. What I am is pro-informed consent. So we need to be talking, and prescribers need to be talking about, if somebody has all the information and they choose to go on an antidepressant, then they need all the information. They need the information on the risks and the balance. And I think in the past, perhaps, I can't speak for everybody, but there's been a certain amount of perhaps fear of speaking about certain risks, but actually there are, you know, there is a suicide risk on antidepressants, and I certainly had that in withdrawal, unfortunately. Again, I never had that before. I am 100% it was withdrawal. I know that now. So that's kind of my message. So that's why I wanted to just put a message out there for those who thank you very much, and follow me on Twitter. I don't get into any kind of debates, or if anyone says anything kind of I don't know what they call them, trolls. I don't kind of engage in any of that. I'm just very clearly I'm still working, and I'm very much withdrawal exists. We need to recognise it, and we need to be telling people all the facts before they can make a decision, because that is what informed consent is. We now luckily have some really good guidance out there, the Morse-D prescribing, which I've now got a copy of, which I will be using when I attempt to come off the medication again. Sadly, I tried, I came off too quick. That was on me. I did a taper over 4 months. It was too quick for me. So I'm looking at a much longer hyperbolic taper. I will be addressing that in the next year or two. There's been a certain amount of trauma, understandably, from the withdrawal. It was really hard. So I want to stay put for now. Again, what I will say is medication, it's an individual thing. I won't be getting into any debates on any social media platform whether somebody should or shouldn't take medication. That's up to the individual. All I'm saying is you need to be given all the facts, make your own decision, have all the information available. The leaflet in the box, you know, that's really important. Read that. That tells you the side effects. Ask your prescriber questions, and withdrawal as well. So thinking about if you choose to come off, again, I'm not suggesting anybody comes off. That's a choice between you and your prescriber, but being mindful of withdrawal and how to do that properly. But as I say, we have guidance on that now. So I just want to cover a few things. I'm sorry, I am looking at my notes so I remember. So we've talked about my perspective has changed. Another thing I wanted to mention is the sort of merry-go-round, which I've kind of noticed. I've moved up now more into a kind of senior role, but I started out working on the wards. And you know, there's very, very good examples of mental health support. But what I did notice sometimes, and it's happening now, and we need to be a lot more mindful of this, and this is for healthcare professionals, that, you know, if a patient is started on a medication, for example, if they're depressed, they choose to go on medication, they've got all the information, they start on an antidepressant, that person, or if it's a young person, that young person's parents need to be told about all the risks, especially around suicide, so that they know what to look out for. They need to be advised of akathisia, which can happen on some of these medications, and they need to be told that so that they recognise that, because what I have seen, and I suspect it still happens, is they get prescribed the medication. They perhaps didn't need it. I'm not questioning that. It's not for me to say. But maybe they had like a normal life stressor, like I did. They got on the medication, that they had an adverse reaction. They got worse. Worst case scenario, they got suicidal thoughts and akathisia. If that prescriber or responsible clinician does not recognise what is happening, the risk is that medication can be increased, or it can be stopped, changed, chopped very quickly, and then along comes, in my view, I'm only speaking from my personal views and experience, say this is not medical advice, but I will speak quite honestly, along comes the emotional unstable personality disorder, which is another point I just wanted to touch on about this diagnosis, which I've seen, and it is a diagnosis. It's not for me to challenge that. But what I'm wondering is whether we need to think about that a little bit differently, because what I've seen is basically people come in with normal life problems. Some people in life get really, really unlucky. They might have had trauma in their childhood. They might have had bullying at work, at school. They might have had really traumatic life. So there's not anything fundamentally, in my view, wrong with that person's brain. But because of the trauma, they develop these issues. They might self-harm as a way of coping. They may get admitted, and then some of the behaviours might be sort of questioned, and then that leads to this diagnosis of EUPD, emotionally unstable personality disorder, which I'm wondering whether, to me it's just a trauma. It's actually, can we not rethink it's not something fundamentally wrong with that individual's brain? Because that diagnosis can be really quite stigmatising as well. It can put up a lot of barriers to other services. People can sometimes have negative attitudes towards people with EUPD, and really, to me, that diagnosis or label or whatever you want to call it really is it's a trauma. It's a trauma because somebody has been dealt a really, upset politely, a really bad hand in life, and is there any room for reframing that diagnosis? Okay, so the other thing I speak quite openly about is preventing polypharmacy. So, and I'll say it again, I'm not anti-medication. That's not for me to say, that's a choice. And if somebody's on an antidepressant, wants to stay on the antidepressant and it helps them, then that is the individual's choice. But what I have noticed is somebody may come in with perhaps no medications, or perhaps one medication, may have an adverse reaction to that medication. It's misdiagnosed as a mental illness, and then in comes other medications. In comes perhaps a mood stabiliser, the antipsychotic, and then you get more medications on top of each other, more side effects, which then ultimately leads to polypharmacy, which in my view is rarely a helpful thing. So I think that's something I wanted to say as well there. So we've touched on that. So yeah, the personality disorder diagnosis, I think, I'm just questioning how helpful that is. I am not in any means taking away people's emotional distress or discomfort or mental illness. I've worked for a long time and I know that mental illness exists. What I am saying is we are, in a lot of cases, over-medicalising, and we are perhaps over-medicating normal life emotions, and that concerns me. Right, so thoughts on care of the young and older adults. So this is something I just wanted to touch on briefly, and this is where it's about risk and balance. So an example, you've got and again, this is only my view, an older person, they've been on a sleeping tablet or an antidepressant for a couple of decades. They've had they've become physically dependent on those medications. Coming off those medications now, would that be more harmful? What should not happen, and what I do want to speak out about so that people have a lot more awareness, and it could happen, for example, if an elderly person went into a general hospital for a UTI or a kidney infection, then they are, and again, I'm not speaking of any examples I know, I'm just hypothesising, they are just taken off all their medications cold turkey. This can't happen. This can't happen. This is where the risk and balance, is questioning, would it be kinder, unless it's a real medical emergency or life-threatening situation, to take an older person off a medication, without any tapering, in a general hospital, is just not good practice. And you know, the oath of medicine, if I believe. I say I'm not a doctor, I'm a nurse by background, but it's first do no harm. And I think we need to always have that in the front of our minds. You know, sometimes the best thing to do is sometimes nothing. And I always remember one of the psychiatrists I work with used to say watchful waiting, which is really good. So it's kind of don't jump in to do something straight away. You know, and that's about risk and balance of prescribing an antidepressant. There may be clear cases where that's clinically needed. But for things, I don't know, for me it was kind of a sort of work-related stress, you know, and as I say, and I've said on my social media, it's not about blame. I'm not getting into that was on me. But what I am trying to do is just spread more awareness, and that's it. I don't claim to be an expert in how to taper. What I do know is we have the correct guidance out there. I'm a lot more informed to help other people and to recognise. And I recognise now that psychiatric medication can come with adverse side effects that can look like mental illness. There's cases where I've known, you know, people taken off antipsychotics and they present with psychotic symptoms. You know, you could argue that that's the pre-existing condition, but in a lot of cases that I'm questioning that. Is that a withdrawal effect? I think we've got lots more to learn. So I'll try and wrap it up now. Sorry, I'm speaking quickly. So final thoughts. So I say I'm just a tiny drop in the ocean, and I've just started to get involved in critical psychiatry, which I find really interesting anyway. My background is, as I say, I'm a nurse, but I also study quite a lot of psychology, mindfulness, so it kind of all ties in with that. And then it all came to a head when I went through withdrawal, which, as I said at the beginning, the symptoms were nothing like what I had before. Times it by, you think I'm exaggerating, but times it by 1,000,000. You know, that was me. I came off too quickly. So I don't know what the future holds, but I do think the more voices speak out, the better. So to say I'm not an expert, but I'm just speaking out from my experience. And just a final thought, and just wonder what you guys think of as well, is I wonder, you know, I disagree with, you know, I think unless there's some kind of organic dementia, there's pathology there. You know, a lot of life's things that we go through, I think, you know, are hugely down to the society we live in now. I think about, you know, kind of where we evolved from. We were sort of in communities, sort of hunters type people. I don't know if that makes any sense. But now we're kind of all on social media, and it's the way things are going, and I don't think we can get away from that. But I think we're a lot more isolated. So I think the society we live in is sick. I don't know if that's coming across right, but not necessarily you or the individual. You will know yourself, of course. But I think it's something to think about. You know, we're spending a lot of time on social media, technology, games. We're looking for the next dopamine hit, which we're all guilty of. Social media, the number of likes, clicks, and everything like that. It's very, very addictive. So that's something I wanted to sort of try, you know, end on a positive note. But, you know, I'm hopeful. I'm hopeful that we have a lot of critical voices out there now, which is a good thing. A lot of kind of, you know, really well qualified doctors that know so much more about this. I only just realised, you know, I had an idea, but going through withdrawal really kind of opened my eyes open to it. So they're my thoughts. And yeah, just thanks for watching. If you've got any comments or any questions, as I say, it's not medical advice. I can give sort of personal experience. I do have a clinical background, so if you want to get in touch with me, I'm on social media, Laura Mills, and I'm quite active at the minute on X. I've only just started, but yeah, just to say that thank you for anyone who's commented. It's really kind of you, and I really like debate. But one thing I won't get involved in is if and I think it's probably a good thing for anyone if insults are thrown, which I'm sure they will be. That's the risk you take with putting yourself out there. I won't get engaged with any of that. I sometimes think no answer is a kind of my answer to I'm not engaging that. You know, I'm simply spreading awareness on withdrawal. I'm not here to tell anyone what to do or whatever. But thanks for watching. Cheers. Bye.